Good morning, everybody. Peter Buckley is my name, and I have the privilege of serving as interim CEO for VCU Health System and also as Dean of the Medical School. And earlier in the week, we had a great privilege of collaborating with the Chamber of Commerce, Chamber RVA, on a similar Zoom session focused on bringing back to business and really hopefully being of assistance to the business community in Richmond City. We had over 600 people registered. We had a very lively event, and by all accounts afterwards, many people felt that it was helpful to them in our preparations. This morning, we hope will be equally helpful, but we're taking a slightly different tack, and we're focusing on VCU Health System, on our innovations, and then also our recovery of clinical services and access, and then also our safety practices. And we do hope that what you can glean from that will also be helpful to you, as also reassuring to the general public that each of our hospitals in this region are very serious about being very safe institutions and committed to high quality care. So we'll spend about an hour discussing these topics. Unlike other businesses, of course, we did not shut down, and in fact, we were open throughout this pandemic and remain so, and that has given us, coupled with the unique expertise that we have in infectious diseases as an academic health center, that plus the lived experience, if you like, of going through this and providing healthcare gives us just a opportunity to share our experiences and our expertise with you. And we have two extraordinarily gifted leaders from our institution to share with you today. And let me introduce both of them. Dr. Ron Clark is the interim CEO of VCU Hospitals and Clinics. Ron is no stranger to VCU and Richmond, and he did his medical degree training at VCU and has essentially been at VCU, I guess, Ron, for over 30 years?
37.
37 years. And when you're in a crisis, you want somebody at the helm who really knows the institution and has the kind of confidence and trust of people throughout the institution. And so Ron has that and has been an extraordinary leader and support to all of us. His credentials are exemplary, including his undergraduate degree at William and Mary, and he's actually a native of Bath County. So he has a tremendous investment in the health of the Commonwealth. We're also fortunate to be joined by Dr. Tom Yackel, who is president of MCV Physicians, which is essentially our academic group practice. Isn't that correct, Tom?
Yes, sir.
Yeah, welcome. And Tom also serves as Senior Associate Dean for Clinical Affairs at our School of Medicine. And previously, he joined us from Oregon Health Sciences University in Portland, where he served as Vice President and Chief Clinical Integration Officer, as well also had a Dean's appointment there as Associate Dean for Clinical Practice. He is extraordinarily well-trained and credentialed. Got both a master's degree and of public health, as well as a medical degree from George Washington University, and he's also completed a fellowship and Master of Science in Medical Informatics, and you'll see shortly why that has been so incredibly helpful, because he's really been able to bring to the table not only a great administrative experience, but also the experience of a practicing internist, as well as a clinical informaticist. And while we're all here at VCU, you can see by our backgrounds, one of our backgrounds is our iconic Egyptian building, and that's probably our oldest building on campus, goes back to 1845. Ron's background shows you the panoply of buildings on the Monroe Park campus. Thank you, Ron. And then Tom is not there, but he's representing our new building, our new facility at New Kent. You want to say a word about that, Tom, before we get started?
I think I've got the most beautiful view right now. It's VCU's newest building, and it almost looks like a rendering of what the building should look like, but this is an actual photo. So we're really excited to have that building open up very shortly for the public.
So that'll be opening just the beginning of June. And we'll highlight that because it's emblematic of what we do. We've been doing what we do since 1838. We have a sprawling medical campus, but we have not stopped during this pandemic. And in fact, we're moving forward, literally opening a new facility in New Kent to fulfill our mission of serving the Commonwealth. We've a lot to go through this morning, but anchoring it is two videos, the first of which we'll show you. The video was made, I guess, Ron and Tom, probably early on in our response to this pandemic, but it's rapid fire and will show you the intensity and rapidity of our initial response as we readied up for this virus. So let's roll the video and then we'll come back and discuss that stage before moving to our reactivation.
Being able to rule patients out for COVID-19 is of critical importance. So doing it in our laboratory quickly is really important. We had to design this test from the ground up so that we can develop a high throughput option here and really would be a potential game changer.
VCU Health is in the middle of conducting a clinical trial for an experimental drug that could possibly treat coronavirus. Dr. Arun Sanyal is leading the experiment.
He explained how the antiviral drug remdesivir works.
The hope is that by making the virus inactive, by reducing its ability to multiply, we will let the infected person's normal defense mechanisms do the rest and heal the person.
The way we do it here in the emergency department is we have a split flow model where patients are initially screened at the front door. If they meet certain criteria, what we'll do then is bring them back into this unit for further triage and evaluation.
Wow. I bet that brought back memories for both of you, Ron and Tom, and the amazing turnaround that you led of making the health system safe as a priority. Now, we did all that anticipating a surge and also watching other health systems and other communities. Tom, to set the stage for where we're at, tell us kind of where we're at, what's happened, where's the surge, what's happening in Richmond, and then Virginia broadly. If you could, that would be very helpful.
Yeah, sure. My pleasure, Peter. First of all, looking at some of that video reminds me that it was only a couple of weeks ago, but it feels like a couple of years ago. And back in those times, of course, we were at a state really before the virus had hit Virginia, and we were watching what was happening in cities and countries like Italy and New York and the UK. And we were modeling different scenarios for Richmond and for Virginia as a state to make sure that we were prepared in the most appropriate way possible. And the approach that we took was that we were going to flex up as strongly as we could while still maintaining our high standards of care. And that's why you saw in the video us looking to previously used hospital facilities like the Metropolitan Hospital and the previous Community Memorial Hospital to figure out how could we still provide true hospital level care for many more hundreds of patients than we're typically used to caring for. Of course, when you think about a scenario like that, we're always happy that we don't actually have to activate that plan. And in fact, we did not. However, we've not seen our last battle with coronavirus, and those plans are ready to be implemented should we need them. What we're seeing right now in the Central Virginia region is a very slow decline in hospitalizations for COVID, and then different responses in different areas of Virginia. The northern region around Washington, D.C., continues to see increasing cases. Although the rate is slowing down, the total number hospitalized goes up just about every day. And then in some western portions of the state, they may only have 3 or 4 patients hospitalized at any one time. So really points out the fact that coronavirus is very much a local or at least regional phenomenon.
Well, that's very helpful, Tom, and you've been a great guide in interpreting those data and helping us through us. And it's very reassuring to know that we have plans still in place should we need them. Ron, on the video, I mean, the video was fast, but so many things were put in place at breakneck speed. What kind of structures, what kind of flow, and then what kind of communication did you oversee to make all of that happen with the teams?
Yeah, watching the video, my heart rate started going back up, and I was remembering those mornings when I was waking up at 3 a.m., which never happens for me. So yeah, there was a sort of a high cortisol error. What we did, Peter, you know, when you have a common enemy at the door, it really helps to focus the team. And the first thing you got to do is play to your strengths and get your leaders out front, get them directed, and then wrap the rest of the team around them. So when we had the COVID-19 knocking on our doors, I first reached out to Dr. David Lanning and Dr. Deb Zimmerman, our chief medical and chief nursing officers, and said, guys, get together a task force because this is going to be big. I don't know what it's going to be, but it's going to be big. So they did with our COO, Paul Weslowski, our VP for facilities and support services, Larry Little, Susan Torti, VP for Peri-Surgical Service, Tracy Fry-Longoria, VP for Ambulatory Care, and the whole rest of the team. They started a twice-a-day task force call. We pretty much put down everything and focused all hands on deck on preparing for this pandemic. That was the first key step, and it wasn't just a random call. We said, we need to know what your priority focus areas are, what do you need, who's got the lead on it, and how can the team support you? So 30 minutes twice a day, and then we would break, go do work, come back, and it was a very fast pace. That was 7 days a week we did that. That was in the first week or so, and then we realized this thing is going to go on, as it has, and as Tom said. So we then stood up our Incident Command Center. For people familiar with healthcare settings, the HICS, the Hospital Incident Command Center, is a concept that's been promulgated and now exists in facilities nationwide, but they're really incident command centers, not pandemic command centers. So you have logistics and personnel and planning and finance and these units that are supposed to stand up, and typically over a few days after the earthquake, after the hurricane, after the whatever's passed, go away. Our command center stood up 24/7 with each of those functions in place and has been running for weeks now. We've gradually been able to step it down as the as the situation has become a little bit more stable, and as Tom said, not quite as bad as we predicted, but just a huge shout out to the team there for being able to provide 24/7 access to leadership for everyone, all 10,000 plus members of our team who had a question, who had a need, could reach out. We would get them their answers, get them their resource, and move. The fourth thing we did was communicate and communicate and communicate. We started daily emails summarizing what was going on because the situation was fast and furious. We started 3 times a week town halls, hour sessions with leadership, a lot of those people I just mentioned, and others, frontline staff members from the ED, from ICUs, from folks who had stepped up to the plate, who stepped back in. We had people, some retired folks who rejoined our team, and we had them featured on the town halls. Again, allowing people a chance to see what was going on and across the breadth of the enterprise. And then lastly, we set up a COVID-19 intranet site where we put all this information, so 24/7 people could go there, find information on all the stuff that was going on. So it was a robust effort.
So Ron, that sounds like just a mobilization of an organization, and also all the people that are going to have benefited, our colleagues and all of us have benefited from the experience. You mentioned command centers are typically short term, but this whole mobilization extending over weeks must have built organization capacity for us into the future.
Oh, I think we flexed muscles we didn't know we had. I think we've learned things. Well, maybe we'll talk more about that later, that we think will carry forward. And yeah, the collaboration and the importance of bringing people together when you can't come together. That was the other curveball that we were thrown, is how do you get people together? Well, Zoom or phone calls or whatever. And despite those hurdles and detours, the team just delivered.
Yeah, remarkable cohesion. You know, Tom, when we went through medical school, we were always under pressure and thought that we learned and were at our most innovative under pressure. But we saw a lot of pressure and a lot of innovation. We're going to show, you saw some of that in the earlier video, but we're going to show a second video that really describes a unique kind of coming together and takes you from concept to the end. And so after that, if you wouldn't mind talking in general about some of these innovations and how this kind of pressure environment and the race against COVID was actually creative for us. So let's roll that video and then we'll come back to you, Tom.
There are several different ways that you can re-sterilize a mask. Ultraviolet light, which we already use in the healthcare setting to sterilize and clean rooms nicely, but we have not been using it to decontaminate single-use products like masks. The process is as follows. The nurse or doctor takes the mask off and places it in a paper bag. It's folded once at the top and put into a plastic bin with a hinged lid. The bins are then transported to our re-sterilization facility. Each mask is thoroughly inspected. If there's any gross soilage, the mask is thrown out. If the mask passes a visual inspection and it has the employee's name on it labeled, we then put it into a bin to be taken to hang on the racks. When 6 racks are full, they're rolled into the room, put around the machine in a hexagonal shape. It takes about 7.5 minutes. The machine runs itself. When it's emitted and received an appropriate amount of light, it turns off. I feel they are safe for use. I am wearing one myself. We are validating that safety every single day to make sure that they're getting an appropriate high dosage of ultraviolet light to kill not only the COVID viruses, but any bacteria or spores on the mask. This has brought out some great qualities and skills that we didn't know our teammates had. And there's certainly some people who have really distinguished themselves that we work with that I think we're all very impressed with and very proud of.
Well, Steve Cates kind of said it all, and that was featured on USA Today, as I recall. So, Tom, tell us about kind of harnessing all that creativity during this pressured period.
Yeah, Peter, you're right. In times of crisis, we all come together to get the job done. And our UV mask sterilization project was a collaboration from not only across the health system, but across our university. As you saw, Dr. Cates, our chair of orthopedics, collaborated with the VCU School of Engineering, and our head of supply chain coordinated with our Health Innovation Consortium. And Steve's right, we brought all of our skills to the table. What he didn't mention was that one of his skills is as a welder. And so those structures that you saw in there, some of them were actually constructed in his welding shop, along with a partnership with some artisans in our community to put those together. So it really was a community-wide effort. And I would say that we've seen that spirit throughout this pandemic, whether it's been around innovation or people providing the emotional support for physicians. I actually got a letter in my mailbox yesterday from two children who wrote me to thank me for taking care of patients. And I could see that those had been distributed to all the physicians, but it was personally addressed, and that was really neat. Getting back to the innovation, though, we've taken all of these methods that we've developed at VCU, and we've shared them with other health systems royalty-free to continue that sense of community from Richmond, from Virginia to the rest of the country.
Yeah, I think that's a very important aspect that we have shared and had great transparency. So thank you for that. You know, one of the things, Ron, you said throughout all of this when we were in the height of trying to prepare is that we never stopped delivering our care. And then we got the governor's go-ahead, if you like, on May 1st to allow elective surgery so that we could help people in need of care. Tell us kind of where we're at now, and then what's the flip side of this story, having kind of made space for people with the virus and then being able to manage that and now coming back and being responsive to the needs of the community. Give us a sense of kind of how that has been managed as well.
Yeah, so to your first point, Peter, you're right. We didn't stop delivering care because it's the core of our mission is to serve our community, and our community still needed health care, whether it was stroke or heart attack or trauma or whatever else came to our doors. We were here. We continued to work throughout it. In fact, a couple areas accelerated, ironically, during the pandemic. Our solid organ transplant program has done tremendous work over the last couple of months. I think they said we're averaging weekly now 6 kidneys, 4 livers, and 2 hearts a week.
Just extraordinary.
Amazing numbers. Our oncology infusion volumes actually went up because we were deferring cancer surgery. So looking at alternative treatment strategies while we were managing through the orders to hold off on elective surgeries. So yeah, we're still here providing care during that. But in terms of the reactivation, the reality was as soon as we told our procedure specialists and our surgeons that they needed to stand down for a minute, they immediately started planning the reactivation. It's hard to keep those folks out of the cath labs, out of the procedural units, and out of the ORs. So led by our surgical chairs, Susan Torti, VP for Perioperative Services, they were ready to go. In fact, they started making lists of patients who needed care, maybe not emergently, but certainly in the near future, so that as soon as the order was lifted, they could roll forward. So it was just a matter of knowing when. Once they knew when, they hit the pedal and started getting people back in here. That included personal phone calls from our surgeons, from some of those who do procedures, because as you know, there's significant concern in the community about, is it okay for me to go get health care? In fact, we've seen that some of the mortality rates are higher than can be explained by COVID-19, and we're concerned that people have deferred care really to the extent that they've harmed themselves and delayed necessary care. So our surgeons reached out, those doing other procedures reached out, and we started pulling back in. In terms of where we are now, our inpatient census did drop. We got down to about 500 patients, which is 2/3 of our typical volume. As of earlier this week, we were back up to 700 inpatients.
Wow.
Census, so that's the majority of the way back, 90+%, and probably next week we'll push that even higher. Our surgeries did drop to 25% of our pre-COVID numbers. We're now back up to about 70%. So again, coming back pretty robustly, but not all the way yet. The ED, interestingly, has been slower. We dropped to about 50% of our typical ED volume, but even that's back up to about 2/3 of where we were prior to COVID.
Excellent. So, Ron, that's really very encouraging. Tom, tell us about the outpatient side of things and what's happened there. You have a great story to tell about telehealth.
Yes. Well, of course, our first step to address the crisis in ambulatory care was to reduce our number of face-to-face visits. On a typical day at VCU, we see over 4,000 patients coming into our clinic, bringing family members, and then leaving the practice. And we knew that we couldn't afford to have a crowded doctor's waiting room in the face of this pandemic. We also knew that we could leverage our telehealth program, which has been around for so many years, caring for vulnerable populations, and under the very thoughtful direction of Dr. Vimal Mishra, our medical director for telehealth. Within 2 weeks, we saw the number of face-to-face visits drop by 75%, but we were able to replace more than half of those missed visits with virtual communications. And in some cases, our departments like psychiatry and neurology were actually able to see more patients with telehealth than they did in face-to-face visits before the crisis.
Wow.
We also found out that patients found these visits much more convenient and were less likely to miss an appointment. I think we've learned some great lessons about providing more care in patients' homes, and I think we're not going to stop doing that now that the crisis has subsided. Now that we're reactivating, we're in a different phase of welcoming patients back into our facilities. But of course, it can't ever be like it was before. So we're working to change our practices to make sure and guarantee we provide a clean, safe environment that patients feel comfortable in when they need a face-to-face visit or a physical exam. We're expanding our schedules for outpatient clinics to ensure minimal time in a waiting room. And in some cases, we're registering people in their cars, doing tests from their cars, bringing them in as soon as the exam room is ready to limit the number of social interactions that they have as they get their medical care. And, when I think about all of the things we're doing, all of the protective equipment we have, and all of the experience we've gained over the past couple of weeks of learning how to manage and live with COVID, I think of all the public places you could visit right now, we actually have one of the safest environments out there.
Yeah, that's a great point to make. The other thing, Tom, listening to you, it sounds that all the efforts made to make the place safe are actually also enabling greater access and customer service. The way you described, almost concierge way of being able to access and get registered real quick. There's no waiting lines, if you like. You also mentioned that telehealth is here to stay. So let me pose to Ron, through this, no one asked for this pandemic, but there are things that were done that, like Tom mentioned, the telehealth, that are going to make us stronger and better as a health system. So what are some of the things that you want to be sure that you capture and keep through this pandemic and they become part of a stronger VCU?
Yeah, I've mentioned a couple of these already because we see the enduring value going forward. First is the daily huddles, which is something we've been doing previously, but the robust engagement of our physician leaders in those huddles Some of our chairmen, Dr. Tricia Syme, Dr. Bob Finling, Dr. David Chelmo, just to name a few at the risk of leaving out others, has been tremendous. And we have been able to accomplish more faster through these daily meetings. I think that's going to continue because it's too effective. It makes us more fleet. It makes us sensitive to what's going on the front line, that deference to expertise of our folks who are out there right on the cutting edge of what's going on. That's a high reliability principle that we have had in the past, but we need to carry even further into the future. Secondly is, again, the value of communication and the transparency. These town halls, we have hundreds of people typically on a town hall that we've now dropped back to once a week because the pace has slowed somewhat. That's going to continue. I think we have dozens of questions that come in. We have great participation from our guests who come in and give a sort of frontline view of what's going on. I think that's hugely valuable. And third, recall, Peter, at the very beginning, we knew this was going to be a stressful period, and we focused on the wellness of the team right out of the gate. So again, our physician leaders, Dr. Amy Grover, Dr. Bob Finling again, Dr. Lisa Ellis, Margaret Rittenhouse from our Employee Assistance Program, our Thumbs Up program. You know, it was more than just worried about someone getting COVID-19, that's enough to worry about. But how are people managing their stress? How are they sleeping? Are they eating well? We've talked about the COVID-15. You know, there are people that are stress eaters out there. Not necessarily a good habit you want to continue. So a really wide and deep effort to make sure that our 10,000 plus team members were coming to work, prepared to do their work. That's something that we need now. We need it tomorrow. We'll need it next year. And I think we'll carry that forward as well.
Well, I think all your team, in a broader sense, Rana, really supported the rest of our team members, and that is another great opportunity for us. The degree of cohesion that you mentioned earlier is really very powerful. You mentioned, Ron, earlier that people may be worried about coming to hospital and care, and Tom, you described some of the measures that really promote high quality and safety. Tell us about how people are worried and how can we reassure them both of the value and need for continued care, but also that we can deliver as a healthcare system both high quality and safe care.
Well, Peter, you know, as a psychiatrist where fear comes from, and it's really our inability to have a sense of being able to do something about a problem that we have little control over. You know, we do know that hospitals and physicians and nurses are some of the most trusted sources for information in our community. So it's time for us now to get the information out there to demonstrate to patients that it is safe to seek care. You know, when you watch those videos of emergency departments in New York and hospitals in Italy, you think to yourself, you don't ever want to go there, even if you're very ill. And the notion of leaving your home and not being able to have your family members with you, I think for some people, they just decided they'd rather stay at home. I think a message that's really important to get out there is that we've learned how to create a controlled environment for care that is orderly, that is clean, that is safe, that is adequately supplied with PPE, testing, and supplies, so we can ensure that patients get the care they need. And frankly, also, for those of us that work in that environment day in and day out, we know we want it to be safe as well. And so it's really critically important, as Ron mentioned. We know that death tolls are up, not only due to COVID, and perhaps in our community, we may have higher death tolls from the results of people not seeking care because of that fear of COVID. But many of these are highly treatable conditions like heart attacks and strokes that we are expert in. And so I hope we can get the message out to people that while safer at home is true in some cases, In other cases, it's safer at hospital.
Great. So thank you for that message, Tom. I think Ronnie, Tom mentioned the phrase "safer at hospital," but our hospital was already safe. And your prior role as Chief Medical Officer, you've been a beacon for securing safety in our hospital. What else has happened now, in addition, to make that even safer, in your opinion?
Yeah. I think that's an important message to get out, Peter, because Tom alluded to the images that are burned into people's memories about Italy and New York City and so forth. Richmond is not Italy or New York City or any of these other areas where they really were in crisis mode. I mentioned a few minutes ago, our ED volume dropped in half. There is no, crush of ambulances at our door. I look back at the month of April, a grand total of 4% of our patients that we were caring for had COVID-19. We did not get the massive surge, thankfully and gratefully. I think some of the public health efforts really kept us out of harm's way. And while those actions are tough, we would have been in trouble had we not gone there. So I think it's important just to set that context. But in terms of what we've done, several things, and we continue to do more. Right now, we've moved to, the video earlier showed testing. We're now testing all patients on admission, because the few employees that we have had exposures to COVID-19 and may have had workplace acquired COVID-19, although that's tough to prove, and it's only a handful. Those were in people that came in that had the atypical presentation or the asymptomatic carrier. So in order to deal with that, we are now testing everybody on admission regardless of their symptoms. We're also testing everyone prior to surgery. Again, to let the patient know, do you want to have surgery if you're an asymptomatic carrier? Probably not. So we can ensure you that you're okay. And for our team members, again, safety for all, that we're going to bring people in a safe way. We're moving to infrared temperature monitors at all of our entry points into the organization for staff and for guests. We have been monitoring temperatures, but we have some great new technology coming in to do that in a very fast and very effective, highly reliable way. So that's good. And then we've added extra environmental services team members to clean some of those high-touch, high-traffic areas where we know rightfully people are concerned about handrails and elevator buttons and some of the public areas with surfaces. We've got to ensure our public that those areas are clean, and we're absolutely putting the resources where they need to be to ensure that.
So if you come in the door of the hospital, what would it look like in terms of, you mentioned some of the screening, but just simply mask? Will you be required to wear a mask? Will you be given a mask? How will that play out? Or how is that playing out?
So I'm sorry, I lost you there for a minute. If that's directed to me, Peter.
Yes, Ron. Yeah.
Yes, to both mask and temperature taking, as we said. And really, those are just basic public health measures, just like hand washing and physical or social or spatial distancing, whatever you want to call it, until we get the vaccine. I mean, we're in this for the long haul. It's going to be a year, maybe two. So we want to know that everyone who's here has done everything that we can do, should do, to create that safe environment. At the same time, we are evaluating our visitor policy to reduce some of the restrictions. We know it's very difficult to contemplate having surgery and then being separated from your family and your support network. We want to do the safe thing. We want to do the right thing. So the team is actively engaged in looking at that now. So that will change going forward, but we're going to do it thoughtfully with science and with evidence and with safety foremost in our planning.
Fantastic. And the other aspect of this that was in the video was clinical research focused on the virus, and this has actually been very much a bright spot. Can you tell us how that has played out, Ron?
It's amazing. I would say of the changes that I've seen in the organization, this is the one that's to me most exciting. The passion for clinical trials and clinical research that this has generated among 10,000 team members is absolutely overwhelming. Almost 50% of our patients with COVID-19 have been enrolled in clinical trials to date, and our clinical researchers continue to crank out more and more opportunities for our patients to enroll in clinical trials. It was interesting, the video was highlighting, well, will remdesivir have a positive influence on outcomes? Well, now we know the science is in. Yes, it does, and everyone's scrambling to get remdesivir worldwide now. And we were on the forefront of answering that critical question. But there's other drugs that are out there being tested, sarilumab, canakinumab. In fact, Peter, as you know, we've now stood up and enrolled patients at Community Memorial. How cool is that? That community hospital has now totally embraced clinical trials as well. So very exciting.
That's a great opportunity. Now, as you look at all of this, which is, you've described, both of you, an extraordinary organizational journey as well as a leadership journey. Take that and tell us, what are the implications for the business community in Richmond, and what advice would each of you give at this stage, given all the extraordinary experience you've had?
Well, I can start off, Peter. I think, first of all, we've learned that it's crucial to create a controlled environment that limits the number of face-to-face interactions that happen at work. And so that means looking at how you schedule, how you organize people physically in their workspace, and look and seek to reduce the opportunity for those social interactions that don't necessarily need to happen. We've all become something of Zoom experts. So if we look polished here, it's because we're on Zoom every day helping to run the health system. I guess if we don't look polished, well, we're just a bunch of doctors, so what do we know? I would also say that this duty that we have to our workers is going to require additional innovation, technology, and getting very familiar with guidelines from the CDC and other sources. And finally, I'd say, remember that VCU Health is here to help, to share what we've learned about creating a safe and productive environment. So we hope everything that we've learned can be a resource to you in the community. This webinar, I think, is just a small example of that, but I think we have lots of expertise to give, and I hope we can find ways to continue to share what we've learned.
Great. Thank you. Tom, Ron, do you have comments?
Yeah, a few. First, Peter, when you say community, I do have to, first of all, just give a huge thank you to the community that's been so supportive of us. Literally, I've been downstairs to the front door of Gateway 3 times in the past week to receive gifts from various folks in the community who are reaching out to us to support our team. The energy and the enthusiasm that we have felt to support the love from the community, it really has helped sustain that in an incredibly stressful time. So just first of all, thank you for that. Secondly, in terms of what I would suggest people do, of course, mask for all. If you're running a business, and as Tom was saying, we're used to this now. We expect people to be wearing masks. We expect to see the little feet on the floor of where we could or should stand, and the wiping down of surfaces. Just ensure your folks coming into your businesses that, we're attending to all these things. And then I guess a lesson learned from us and our surgeons is reaching out to your consumers, to your public, whoever they are. That personal touch, we know is difficult in these times, and people are feeling somewhat isolated. A phone call, an active outreach from you probably makes a world of difference to people right now, because there are questions, there are concerns, and that human touch is so important. I think we've come to realize just how important it is in an era where we've been forced to be isolated.
Those are great points. We're going to move now towards questions. We've had a number of questions. I hope we'll try to get to as many as we can. Tom, I'm going to begin with you. A question about all our outpatient clinics open, and then specifically, is Stony Point and the Now Clinic open?
Yes, we have opened all of our practices. We're working to make sure that the scheduling is done locally in the practice so that we can coordinate and gate the flow of patients through the practice. We're also looking at coordinating that, because oftentimes when a patient comes to one of our outpatient facilities, they don't just come to see their doctor. They also may stop off and get phlebotomy. They may need a x-ray done. So we're working to coordinate all of that flow through the outpatient facilities to avoid crowding and unnecessary social interactions.
Yeah, great. Okay. Ron, a question about our food services and our cafeteria. What precautions have been taken there?
Yeah, they stepped up early on. So obviously, like most places, we got rid of the self-serve salad bar, soup bar, etc. It's now all single package. We've got the lines laid out so folks know how far to distance themselves. Actually, our reduction in our volumes was a natural byproduct, because it put fewer people in the cafeteria during times. And then the seating areas, we removed seating so that folks could come and sit down and have their lunch or dinner or breakfast, what have you, but weren't violating the social distance, physical distance standards. So yeah, all those things that you've seen in other places, we've implemented here as well.
Great. There's a question I'm going to try to answer about opening of the dental school, because of course, as both of you know, we're not just a healthcare system, we're an academic system. And so we have dental students, we have medical students, we have allied health students, nursing students, and they have all been very professional and patient, practicing that social distancing, moving their learning to online. But of course, because they're clinical specialties and because we need to fulfill our mission for the Commonwealth, we need to bring those students back safely on campus. So specifically with regard to our dental school, the degree of coming togetherness, Ron, you mentioned the cohesion. We really marshaled all our expertise, both on the university side and on the health system side, to restart our dental school. We'll be starting our dental clinic shortly. Obviously, many accommodations, given that the coronavirus spreads by droplet, many careful accommodations in line with national standards for dental care have been put in place, as well as security checks and walkthroughs and physical changes made to make sure that safe dental care can be given. And that's the first step, because then as you bring back the dental students, we're fortunate, we have some fantastic simulation labs, and so we've been figuring out how to make the social distancing, and then you mentioned all the cleansing, Ron, to get that right, to be able to bring students back to the dental lab. And then once our dental clinic, the clinical side of it is up and running, we'll of course then offer that opportunity over time in the same phased-in, safe way that President Rao has also been talking about, to make sure that we have our responsibility towards our health professional students, and in fact all our students, with a intended fall semester opening that we are working as one group on, again marshalling the talent across this very large university and health system. So we're going to be able to refine our mission from an on-site, online service back to simulation and then back to clinical care. And that is part of what we do, and excited to be able to do that.
Yeah, Peter, just to tag on that for a second. So you mentioned opening the dental school. So yeah, the power and the value of one VCU is one of the other major takeaways, I think, from this. We sent, as you know, a team of 6 of our epidemiology facilities experts over to the dental school to help them put together a plan for that. And then one of the other questions sort of tagged onto that, how's VCU Health working with Monroe Park campus on opening? I was just on a phone call this morning with Melinda Hancock, Meredith Weiss. Right after that, I got an email from Thomas Briggs because that planning and that collaboration has been full on here for weeks now. So absolutely, having both campuses come together to support each other during this has been very powerful, and is one of the other things that will continue after far after COVID's gone.
Great, thank you for that comment. A question here, Ron, at the Ambulatory Care Center, the ACC, will there still be lots of people waiting? Either Ron or Tom, if either of you take that.
So I think Tom was speaking to that earlier.
Yeah.
Yeah, sure. I'd be happy to. You know, we are doing everything that we can to avoid that from happening. So that starts with looking at how many patients we schedule per hour in a particular practice. You know, for some specialties, you know, the time spent in the office is relatively quick. You get your knee examined, you get an X-ray, and you go. You know, some physicians may wind up having visits every 5 minutes. That brings a lot of patients per hour through the building. So we've been taking schedules like that and spacing them out, say taking someone who had 5-minute appointments out to 20 minutes. And then we test it and we see, because again, there's so many different things happening in the building. And then as we learn and we say, nope, that was a safe environment, then we look and see, well, can we see a couple more patients that day? The other thing that we're doing is extending hours in some of our buildings and locations so that we can spread patients out throughout the day. We're also adding weekend services in some cases. The goal is to create as much physical distance between patients. If they are in a waiting room, we've marked all of the areas or rearranged the furniture to promote that physical distancing. We have markers on the floor to help people if they need to be in a queue to wait in a way that they're distanced. But we're really just trying to avoid having to use those measures altogether by promoting a flow that is continuous and avoids waiting as much as possible.
Terrific, thank you. Ron, a question here, will VCU Health Anywhere have a wider launch? So I think that's an opportunity to talk about, we mentioned the new Kent. What else is happening in terms of our broadening of our services?
Well, I think that speaks specifically to the telehealth services. And as Tom mentioned, that's been a VCU Health Anywhere's incredibly powerful tool. We're looking at how we solidify the roughly 50 to 75% of our visits that are now occurring by telehealth and carry that forward, just reducing the time and space barriers for patients to come here to see folks, to get care and to go back home, particularly if you have a child or you have a job. It's just removed so many barriers. It will absolutely be a much more robust effort going forward. But obviously, this it's been a bit of a tsunami. We now just have to make this part of standard work as we incorporate it into the daily planning and care that we want to deliver going forward.
Great. And then, of course, on the building side, I'm looking at your screen behind showing buildings, but we also are committed to a children's hospital. We're committed to a ambulatory outpatient. You see, Tom, we've got the new Kent building right behind Tom, and then also we have an extraordinary partnership and new building in association with Sheltering Arms. And so we haven't stopped through this, Tom and Ron, as both of you have highlighted before.
Yeah, Tappahannock, new member of the family, just to the northeast of here, and a growing partnership with our colleagues to the east at the Riverside Health System. So yeah, lots happening.
So let me get back to another specific question, Tom. This is, let me read it. I've read that children under 2 should not wear masks due to possible suffocation. What should parents do to keep young children protected when they come in for a well child visit at the Children's Hospital?
Well, first of all, I'll say I'm definitely not a pediatrician, and I don't want to pretend to be one on Zoom. However, I know that in all of our ambulatory environments, we're giving very specific information to people so they know exactly what to do. And of course, with all this, we have to weigh the different risks that are present. COVID is not the only risk, as this particular piece of guidance recommends. So I would say follow the advice that you receive. And also, if you have a question, give us a call and let us figure it out. Because the other thing that we've learned through this is that we are continuously learning. Just because something was the recommendation 3 weeks ago does not mean that that's the current recommendation. So when in doubt, please reach out to us and we will get you the most up-to-date information.
Ron, do you want to come in there on that?
Well, I was just going to make the comment that folks should remember that the primary purpose of wearing a mask is what's called source control. It's so that you don't spread to others. So the child coming in who doesn't have a mask on, you know, their safety is really not that much compromised by not wearing a mask. But Tom's right. Our pediatricians and pediatric care team would be more than happy to work through those. And keeping a mask on a 2-year-old, I can imagine, has its own challenges. So they'd be glad and are very familiar with working through those issues with you.
Great. Look, you've both done an amazing job both through this crisis and really demonstrated your healthcare leadership. But actually also today, this has been really informative, and you've gone from broad public health to right into the details and granularity of running a hospital. So I congratulate both of you on your leadership. It's been absolutely stellar. Unfortunately, we've come to the end of time and we haven't even answered all the questions. So apologize for that. If we have emails, we'll certainly email out responses. We are here to serve you in the community. And so if there's any additional communications way we can help you, we're absolutely committed to do that. And Ron, as you pointed out, we've been in a way more fortunate than other communities that while the virus has visited and is at a level deadly for some, it's really not been as devastating as in other countries and in other cities. And so we're also very fortunate to have a strong and vibrant business community. And we really, as you said, we really appreciate both their support, but also the reciprocation and our ability to work with the community, because we're really in this together, and our ability to work forward, as both of you have said, this is going to be a marathon, not a sprint. And so our ability to serve and help each other, I think, will really make a difference into the future. We want to thank you for your support. We also recognize that you have supported our research, our education, and our clinical activities, and many of you have asked us, how can you continue to support? So in March, we did establish directly a COVID-19 fund at the MCV Foundation to be able to support both clinical, educational, and research activities. And if you'd like to learn more about that and even give towards that, please do visit our MCV Foundation website at www.mcvfoundation.org. I'm sorry to say we've come to the end of the time. We appreciate what you do for the Richmond community, and we feel very, very privileged to be a part of that community and contribute as we can. So wishing you a safe and healthy weekend. Thank you. Ron and Tom, thank you both very much for your leadership.
Our pleasure.